Good morning, everybody, and welcome to the P&A RCSI Faculty of Nursing Autumn-Winter webinar series. You're our most welcome joining us on this very bright autumn day, and I know many of you are busy at home and in your work lives. We've children off, we've got stuff going on, so we do really appreciate you joining us in such busy times, but I guarantee you'll be most engaged, and whether you like it or not, Nora will be engaging you, and it will be quite an active session both this week and next week. So I'd like to introduce Hanora Byrne. Hanora Byrne is a colleague actually and friend of the P&A and the RCSI, having completed many of the actual both webinars and indeed the face-to-face CPD programs in the RCSI P&A College. Nora is a psychiatric nurse. She registered, and she also holds a BSc in psychology. One of her main passions is clinical supervision, and she holds an MA in addictions. She probably will talk to you a little bit about one of her other qualifications, which is a certificate in CBT and motivational interviewing. That will come into play, I think, in the two programs that we have lined up for you quite a bit. Currently, Nora is working in an eating disorder unit in North Dublin, and I know she is very passionate on this subject, and those of you who have met with Nora before will know that there's always something to learn from every one of her sessions. I certainly can vouch for that. So you're most welcome, Nora. I also want to take this opportunity to thank Catherine Cluma-Vanni and Anya Halligan, and indeed Professor Thomas Kearns, for co-hosting this initiative with us. I think it's really good initiative in this towards the end of the year, and we are very happy to collaborate also, but indeed very grateful that this is going so well. So many thanks to you both. Thank you.
Morning, everybody. Thanks, Aisling. And my name is Catherine Cluma-Vanni. So as always, we're delighted to work with our colleagues in the P&A and in our continuing College of Professional Development. I'm just here briefly to tell you that this week we're going to look at dual diagnosis, mental health and addiction, the challenges nurses face. Now, next week, for those of you that are interested in using the tools for assessment that Nora will talk about briefly today, we really want to give you the opportunity to work with the tools around some scenarios. So what we're going to ask you to do, if you'd like to do that, to log on again next week, that if you give us your email, we will send you, it's not a huge amount of homework, it'll just be some nice scenarios from real life, obviously real world practice, where you can have an opportunity to try the tools. And next week then, Hanora is going to talk about the evidence-based assessment tools, which support all of the dual diagnosis, mental health and addiction, and the issues that you see there in clinical practice. So hopefully, if you're interested in that, please pop your email in when you sign the form, and you also need to sign the form there. It's on the chat box for to register for your CPD certificate. The other thing we would like to ask you to do is pop all your questions in as you go through the session. Write them in real life time, and then myself and Anya at the end will come back and read them out and present them to Hanora, and she will hopefully have answers and guidance and advice for all of us. And just to say that there's a lovely program, hopefully, of events that are of interest to many of you on the P&A website. And again, colleagues from clinical practice, many of them advanced nurse practitioners, clinical nurse specialists, and nurses with huge expertise are available over the coming weeks to share their information, their expertise and their knowledge with you. So without further ado, there's over 15 of you on now, which is absolutely brilliant. We're delighted so many of you are here. I'm going to hand over to Hanora Byrne, and thank you, Hanora.
Hello everybody. I'm not sure whether I'm live yet or not. Am I live? I am.
You are, yes.
Okay. My name is Hanora Byrne, and I suppose I've swung from everywhere from child and adolescent psychiatry right through to forensics and all the bits that have kind of come in between that. And I've ended up that my passion would have been for dual diagnosis, mental health and addictions. So I'm just going to fly through. There are a lot of slides here. Some of the slides I will just briefly touch on, but I think for yourselves after, the whole kind of presentation will make a bit more sense once you have the slides anyway. So here we go. So the programme today, we're going to look at mental health and illness, addiction, dual diagnosis, challenges for nurses, treatment approaches, and feedback on any questions. The mental illness, what is it? What causes it, and what can we do about it? Mental health. I suppose looking at the two, we always talk about we all have mental health. We talk about I'm going for a walk for my mental health. You know, I'm going for a run because that'll do my mental health a bit good. But we don't actually, and that would do to do with maybe you're feeling a bit down yourself, a bit low, a bit of anxiety or whatever. But mental illness kind of infers that it's an illness. But mental health here is mental health problems that we all experience: work pressures, poor concentration, sleep disturbances. Such problems are usually temporary. They're relieved. They're relative to the demands of particular situations. They respond to support and reassurance. And down here, the World Health Organization state it's not just the absence of mental illness. It is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. And I suppose that's slightly different to what mental illness is. Mental illness is a state of mind of a person which affects their thinking, perceiving, emotion or judgments, and which seriously impairs their mental function to the extent that he or she requires care for mental treatment in his or her own interest or the interest of other people. And all of us suffer from mental health problems at times. I used to always kind of tell my patients, you know, that depression, we all suffer from depression. There are various levels of depression. If we've lost somebody in our lives, we're going to feel not like going out singing and dancing and having a party. We are going to be low on our mood. And okay, we don't need treatment for it. But when you look at that kind of a feeling that you're going through, if you have experienced loss or bereavement in your life, you know, somebody who actually needs to be admitted to hospital, it's 100+ times more than that. You know, so we all do experience it. Mental illness can be defined as experiencing severe distressing psychological symptoms to the extent that normal function is seriously impaired. Think of an exam. How do you feel before you do your exam? The stress, the anxiety and the worry. Multiply that up again and again, you know, it becomes, you need treatment. Diagnosis is made by using Diagnostic and Statistical Manual for Mental Disorders, which is the DSM, or it's also the International Classification of Diseases, the ICD-10. Depending on where you are, what hospital you're in, it can be either or. And sometimes they'll crisscross because they're not 100% happy that the ICD is giving a clear-cut diagnosis. They may actually look at the DSM. So if we look here, we have the ICD-10 is the international classification. There is an ICD-11, and that will be coming into effect. It's there already. It'll be coming into effect in 2022. However, they think it will not be fully used by every country in the world until 2027. So it's the International Classification of Mental and Behavioural Disorders, the clinical descriptions and diagnostic guidelines. So mental and behavioural disorders due to psychoactive substance use. Here we have psychoactive substance use is in here. It's a dependent syndrome, may be present for a specific substance, tobacco or diazepam. It's strange there, like, you know, you think that tobaccos are sold everywhere and anywhere, and yet here in the ICD, they're looking at tobacco or benzodiazepams. For a class of substances, opiates, for a wider range of different substances, individuals who feel a sense of compulsion, regularly to use whatever drugs are available, and who show distress, agitation and or physical signs of a withdrawal, you know, state upon absence. Includes chronic alcoholism, dipsomania and drug addiction. So now we have in the ICD-10, which is a diagnostic tool used to diagnose mental health and disorders, we have here substance abuse added in. The American Psychiatric Association's current Diagnostic and Statistical Manual of Mental Disorders, which is DSM-5, defines substance dependence as when an individual persists in the use of alcohol or other drugs, despite problems related to the use of the substance. And it goes on here, substance abuse is considered substance use disorders. Terminology is slightly different. You know, you have, you know, substance abuse disorder here, and above you actually have more defined into alcoholism, dipsomania, and drug addiction. They both have it listed as part of a mental health problem. We'll get onto that later. What is mental illness? Mental illness refers to a wide range of mental health conditions or disorders that affect your mood, thinking, behavior. Examples are depression, anxiety, schizophrenia, psychosis, schizoaffective, addictive behaviors is in there as well, and compulsive obsessive behaviors and eating disorders. Many people have mental health concerns from time to time, however, they do not require inpatient treatment. Individuals may also present with one or more of these conditions. It's strange to think, like, you know, that the eating disorder unit that I work in is actually under the Mental Health Commission. People don't think that eating disorders is a mental health illness, but it actually is, and it states it here. How do people get a mental illness? Is it inherited? Is it environmental? Is it brain chemistry? Like, you know, what is it? People don't want to talk about mental illness, but we're quite happy to talk about our mental health. Well, I'm going for a run in the park because it's for my mental health. But yet we're talking about mental illnesses, stress, anxiety, pressure at work, but we never call it a mental illness. There's such a taboo still around it outside there. Percentage of people worldwide who have a mental health illness. This is interesting because you can't see it. People who have a mental health problem don't look any different. You know, people who have a dual diagnosis, they don't look any different to somebody who has a mental health problem. As somebody who just has an addiction, they don't look any different either. But what are the percentages worldwide? Mental health disorders are complex and can take many forms. Now, this is just on mental health alone. The World Health Organization has recognized the findings from long-term studies that show up to 70% of those diagnosed with schizophrenia and 80% of those diagnosed with bipolar disorders recover or improve significantly. When they're fine, they're absolutely great figures. However, you know, I suppose when you look at the amount of people who are homeless and that may have mental health problems, you wonder, do they ever recover? Do they ever get well? Are they just being abandoned, put out in the streets, you know? But they are. Think about the old institutions gone by that had over 2,000 beds in them. They're not there anymore. So it's showing that 70 and 80% of people diagnosed with mental health problems get to go back out into the community and live healthy, active lives. The following table presents data on diagnosis made according to the World Health Organization, the ICD-10. The chart represents the latest estimates of mental health disorders and prevalences. So I'm just going to show you this here. So if you look here, okay, so any mental health or substance abuse disorder here, there's 1.1 billion worldwide. It's in 2016. And it goes through the breakdown for depression, anxiety disorders, bipolar, eating disorders, schizophrenia. Schizophrenia is 21 million. And then you look at drug and alcohol use down here, 100 million. And drug use only without alcohol is 62 million. And I mean, like, in relation to the, if you break down male and females, I mean, like, that's something that we're hearing a lot about on the news with the COVID at the moment. They're always giving the male and female numbers. You know, any mental health and substance abuse disorder, they're fairly level there, 15% males, 16% males and 15% females. You come down here then to depression. And yes, there are more females, 4.5% females compared to 3% males. Anxiety, it's more females as well, you know. And a lot of the times, you know, we know men that are very anxious, but they seem to mask it a bit better than females. Bipolar affective, again, there are more females. But when it comes down here to eating disorders, you know, more females. And again, that's something that you think of. Women are more likely to want to, you know, have a preoccupation with their size and body image. Schizophrenia, it's fairly equal there. And again, when you're going down to alcohol, there are more men. 1.9% as opposed to 0.8% females. And drug use, again, there are more males than females. Addiction. So what is it? What causes this? And what can we do about it? They're the same 3 questions I asked you in relation to mental health. The reason is we're looking at dual diagnosis. And a lot of the time, the treatment outside there, addiction services will say there's a mental health problem that we don't know anything about. And in the mental health services, they say it's an addiction problem, but we don't know anything about addiction. You have 2 conditions in the one person, and both need to be treated together. And we'll talk about that a little bit further on. So addiction here, it's a chronic relapsing behavioural disorder with remissions and relapses. It's defined by tolerance, withdrawal and cravings. We recognise addiction by the person's heightened and habituate need for a substance, by the intense suffering that results from discontinuation of its use, and by the person's willingness to sacrifice all to the point of self-destruction for drug taking. I was once told by a client when I was building my credit hours up outside in an alcohol unit, that the biggest love affair, and it was just so passionate, the biggest love affair that he ever had was with the drink in front of him. You know, and that in itself to me, and I can still see him, it's just so overwhelming. So dependency. Now we've used the word addiction, we've used the word dependency here. And again, they're different words, and we're going to come across that in a little while as well. So dependency, you have a chemical dependency, substances that are either legal or illegal, drugs and alcohol, and non-chemical, which is gambling, eating, sex and shopping. So how do people get addicted? Psychological factors, again, stress, depression, anxiety. We mentioned those when it came to mental health as well, and mental illness, stress, depression and anxiety. Then you have personality, psychiatric disorders, self-medicating. Environmental influences, so their exposure to physical, sexual or emotional abuse or trauma, substance use or addiction in the family or among peers, starting with alcohol, nicotine or other drug use at an early age, genetic predisposition. Sorry, going back there to the starting alcohol and nicotine. There's a lot of hype at the moment about those e-cigarettes, that young children are starting on those e-cigarettes which contain nicotine, but they don't contain the other harmful elements of a cigarette, are now actually craving proper cigarettes, and it's probably a gateway into using other drugs at this stage as well. We have a genetic disposition. We also had a genetic disposition with mental health, and we're going to come back to that in a little while. Certain brain characteristics that can make someone more vulnerable to addictive substances than the average person. Okay, that's a little bit of one that you can think about. Do you agree with that or not agree with it? Having one or more of these addiction risk factors does not mean someone will become addicted, but it does mean that the odds are greater. The more risk factors present, the greater the chance that the individual will develop the addiction. So here we are now, we're looking at addiction. You have the psychological factors, the same as mental health. And in the 2, they both have stress, depression and anxiety. Environmental exposure. You have physical, sexual or emotional abuse, trauma, exposures to addiction in family or peers for the addiction side. On mental health, you have fetal exposure to alcohol. We know about fetal alcohol syndrome, and drugs can be linked to mental illness. Genetic predisposition. Certain brain characteristics can make someone more vulnerable to addictive substances. We know about our dopamine levels in our brain, and the effects that cocaine have on different segments in the brain. And you go to the other side here for mental illness, the genetic predisposition here. It is recognized that bipolar sufferers actually have lithium level deficiencies. Schizophrenia, there's a genetic link for schizophrenia, and endogenous depression, there is a genetic link for endogenous depression. Endogenous depression is a very deep-rooted depression. It's not like someone who is like a reactive depression who's reacting to an event, and they may need treatment for a short time. Endogenous depression is a long-term illness that requires treatment probably for most of their lives. There's an Australian study done in 2010, and I'm just sticking this up because it's just kind of giving us room to talk about a few other bits as we go by. And this was looking at 2,000 individuals they were treated in the community. It was presented at a conference in Tokyo in 2013. And this is feedback from the people. Most of the individuals living in the community, that's 98% of those 2,000 people, they were asked to identify their top 5 challenges that they would face in the next 12 months, and the top 5 were, now these were people who had mental health problems, schizophrenia and psychosis, but they didn't have any addictions. Was the top 5 they mentioned were the lack of money, social isolation, lack of employment, poor physical health, uncontrolled symptoms of mental illness. Okay, the reason I stuck this up is take out psychosis, take out schizophrenia, and put in addiction. Those are probably the same 5 top problems that someone who has an addiction would actually face. Add addiction with psychosis and schizophrenia, and it's still the same top 5. So you can see how both conditions are interchangeable, very similar, and are extremely difficult for nurses when it comes along. These are the challenges that nurses face. I'm just going to talk briefly about some of the mental health commoner, I suppose, conditions that you'll find outside there. Bipolar affective disorder. When I'm talking about it, with addiction, you can see that it's very difficult to know, is this addiction or is it mental health? So bipolar affective disorder is a mental illness that causes disturbances in a person's mood, energy, and ability to function. Individuals with this disorder can experience extremely high moods or euphoria, which is mania. There are drugs out there that can cause this as well, without having a mental health problem. And extremely low moods like depression, somebody coming down off heroin, they're going to become very depressed as well. Severe mood swings that can occur generally last for weeks to months time, and can result in significant disability through damaged relationships, difficulty with employment, and significant risk of harm because of reckless and impulsive behaviour. This is bipolar affective disorder. I suppose for those of you who don't work in mental health, this would be the guy who gets up at 2 o'clock in the morning, cuts his grass, cuts his hedges, and then decides, oh, the neighbours, their hedges need a bit of cutting as well. I'll do their hedge. The one beside them, I'll do their grass. So it's this type of a euphoria that's ongoing, and there's no malice there as such. And at times, it can get a little bit worse as well. Anyone can develop bipolar, but it is most common between the ages of 18 and 35. And again, it's the ages here, because we're looking at mental health, but if you look at addictions, the worsening of addictions can also happen from the age of 18 upwards. About 1 in 100 people develop bipolar affective disorder at some stage during their lives, and it is as common in men as it is in women. The genetic part of it, or I suppose the organic part, is imbalances in lithium levels have been identified as contributing factors, along with a genetic predisposition. So somebody who is on a lithium will have to have their bloods done on a regular basis, about every 12 weeks. And it monitors the level of lithium in their brain, and their medication can be either increased or decreased according to those levels, or just left as it is. It has been noted that stress can also make further episodes of either mania, depression more likely in those who have developed this disorder. So if you have somebody now with COVID here at the moment who's being very well managed at the moment on their medication, they suffer with bipolar affective disorder, they can be functioning to a very high level, and COVID sets in. They're not going to work, they're working from home. Do I have a job? Another lockdown. All of this stresses can actually trigger their bipolar to either become into that depressed state, or they can actually go into more of a manic state as well. Schizophrenia and psychosis, and a lot of the time people actually kind of put the two together. I'm just using the two together here because it's a little bit easier, but there is a slight difference in them. Schizophrenia is a major mental illness that causes disturbance in thoughts, perceptions, emotions, and behaviours. Again, very similar to the bipolar. It affects about 1 in every 100 people, much the same again as the bipolar, and usually occurs first in adolescence or early adulthood, ages 16 up again. So now we're looking at an early age of 16 here, 18 for bipolar. Again, similar ages here are setting in for addiction, although it can also occur later in life. more psychiatric inpatient beds than any other illness. So it's actually the ones that take longer to help, and they're the ones that are mostly in hospital. People with schizophrenia can sometimes find it difficult to distinguish between what is real and unreal. It may be difficult to think clearly, manage emotions, relate to others, and deal with everyday life. There are different subtypes, and they include paranoid schizophrenia. So you can have somebody who's extremely paranoid, and they can have a paranoid psychosis, or they can actually have paranoid schizophrenia. You have somebody who's taking a lot of cannabis. They can actually have a paranoid psychosis, which can, if they're predisposed, develop into paranoid schizophrenia. So that's the genetic link there. If you have a history of schizophrenia in somebody's family, they may develop schizophrenia from cannabis use. Schizoaffective disorder has got to do with somebody who might affect their moods, and it says it up there, and their emotions. Catatonic schizophrenia is not actually seen that often. It's a type of schizophrenia that people have unusual gait, unusual stances. It can stand in peculiar situations, or sit in peculiar, odd situations for can be up to hours at a time. Disorganized or hebephrenic schizophrenia, again, it's a different type of schizophrenia. It's people who are probably in the younger age bracket. Schizophrenia is divided into two types, right? So it's active symptoms, referred to as positive or psychotic symptoms, and passive symptoms, as referred to as negative symptoms. This is getting a little bit more complicated here now for people who are not in mental health. So positive symptoms are what you see at the moment, they're the hallucinations. These are usually, these are unusual or unexplained sensations that can affect all senses. They can hear things, you know, or other sounds, that is most common with the hallucination. They can have a delusion, which is a fixed belief, which is not usually true. And their thoughts, they have thoughts that are different to what's normal as well, and they can express these through abnormal spoken language. And it looks like they're having a conversation with you, but there's somebody else there as well. Going back to, I suppose, delusions and their fixed belief, somebody once told me that when you're looking at reality, you know, a delusion is somebody who builds castles in the sky and they live in them. So a negative symptom here is they tend to be longer lasting than positive symptoms and include flattened mood, apathy or low mood, loss of pleasure, and lack or low amount of speech or limited content of speech. And they're the things that you don't kind of see. Oh, she's sitting very quietly there. Actually, she's very quiet anyway. She doesn't talk very much. Whereas somebody who is hearing voices, their heads are moving, they're constantly turning because there's someone behind them listening, or they can hear the voice coming from the side of their ear from behind them. Or somebody walks in. By the way, we all suffer with paranoia. So if you're in a room, if you walk into a room and you've got your back turned and someone starts to laugh behind you, you'll automatically think, if you've been to the loo, if my skirt pulled up behind me, is there something stuck on my back, you know? So this is paranoia that we all have, but it's when it goes to the other extreme and you're living with that paranoia, the amount of energy that's taken up in trying to figure out, is this true, is it not true? And the fear of if it is true, like it's torture. So the prevalence of mental illness, okay, all mental illnesses are associated with an increase in occurring substance use compared to the general population. However, people with the most severe psychiatric illnesses have a higher rate of co-occurring substances. The 17% among the general population, whereas there's 47% of people with schizophrenia. 56% for people with bipolar and 30% for people of all other mood disorders. So that's quite high, really, those figures. And I suppose you're seeing that outside yourselves and people coming in. And it is hard to know in a treatment service, is somebody, you know, standing or looking or behaving the way they are because it's their drugs they're taking, or is it mental health? And they're telling you straight up, I have taken nothing. Take my urines, do whatever, I'm clean, I'm clean, I'm clean, you know, and it could be mental health. Substance abuse and mental illness, higher rates of substance abuse and in people with severe mental health problems in the general population. Young males with chronic mental health problems are more likely to have a comorbid substance misuse. Young males are also overrepresented in a forensic population. If you just look at our prison service, we have the Docus, with I can't remember how many beds they have now, but we have 14 prisons in the country, and we have the Docus is one. There's a unit down in Cork, and I'm not sure whether there's a unit in Limerick as well, but the rest of them are all for males. So that just shows you that there are more males involved in the forensic population. Severe mental illness such as schizophrenia and affective disorders are most associated with comorbid substance misuse problems. And when we look back at that chart I showed you at the beginning or earlier on, there were more patients with schizophrenia that were male compared to female. I think it was 1.9 comparison compared to 0.8%, if my memory serves me right. There are also, these are also the most common diagnosis among forensic populations, and dual diagnosis is indicative of a significantly worse outcome. So, addiction and mental health, 2 problems, 1 person. The definition of dual diagnosis. We've looked at mental health, we've looked at addiction, we've done them very, very quickly. This program would normally be done over 8 hours, and today we're cramming it into an hour and a half, so it's really kind of a rush through, and I'm sorry for that, but it's what we can do, and it's a great thing that the RCSI are doing. So getting back to the definition of dual diagnosis, comorbidity or dual diagnosis is defined by the World Organization as the co-occurrence in the same individual of a psychoactive substance use disorder and another psychiatric disorder. According to the United Nations Office on Drugs and Crime, a person with a dual diagnosis is a person diagnosed as having an alcohol or drug abuse problem in addition to some other diagnosis, usually psychiatric, a mood disorder or schizophrenia. The coexistence of both mental health and substance abuse problems for an individual, and that was McGowan in 2004. It's also the Vision for Change 2006 definition as well. Terminology. So this is where it now gets really confusing. If you go on to Google and you search dual diagnosis, you'll get X amount. You go on and you Google comorbidity, you'll get this amount. You go on and do co-occurring substance abuse and mental health, and you get another amount. You also have here the MICA, mentally ill and chemically abusing. You can also look at the MISA, mentally ill and substance abusing. Then you have the CAMI, chemically abusing, mentally ill. And then the SAMI, substance abusing, mentally ill. And then you have the MISUD, mentally ill and substance use disorder. Terminology, it's all the same thing. Wherever you are, it's always something different, but meaning the same thing. The bar in 2015 refers to the term dual diagnosis being interchangeably used in practice and in literature with other terms including comorbidity. It's difficult, you know, if you're looking for stuff out there, and depending whether it's America, other parts of Europe, in the UK, in the north of Ireland, the terminology is different. The Expert Group on Mental Health Policy 2006, it's concurrent disorders. Coexisting drug and mental health problems, the Working Group on Drug Rehabilitation in 2007, and co-occurring mental health and substance abuse problems here at Todd in 2010. All different. So, when you talk about dual diagnosis, the terminology is all over the place, up in the air, basically. So, what are concurrent disorders? Concurrent disorders are any combination of mental health and substance use disorder. Some examples are, for example, anxiety disorder and drinking. You don't have to have a mental health diagnosis of anxiety, and you don't have to have an alcohol problem, but here you have anxiety and a drinking problem. People who are anxious will take a drink. Schizophrenia and cannabis dependence. I've already mentioned that cannabis can actually exacerbate schizophrenia, and it can also, in somebody who's predisposed, actually cause schizophrenia. Borderline personality disorder and heroin dependency. Depression and dependency on sleeping pills. Depression can also be dependency on alcohol. However, 1 + 1 may equal 3, 4, and 5. It's not always 1 + 1 = 2. As you know, people with depression, they take sleeping pills, they'll take benzos, they'll take alcohol. Someone who's a heroin addict, they might have a borderline personality disorder, but the come down off heroin is depression. A combination of mental health and substance use problems can create more problems. So you have somebody who doesn't have a mental health problem and they're taking drugs and they want to come off the drugs. The depression hits them, you know. Do they need treatment for depression? Are they now suffering from depression? Do they have a diagnosis of depression? Or is it just the come down? I have met several doctors who have told me over the time that no, they do not have a depression, it's a come down off the drugs. However, when you do certain assessment tools, you can actually come back and say, well, I'm sorry, you know, I accept what you say, but I've used a validated assessment tool that shows that Mary Jane or Tom Jones actually scores this, and to me, it's not the come down from the drugs, it's actually depression. And maybe that they were depressed before they took the drugs and were self-medicating. So you can see that whole kind of scenario going around there. But having the assessment tools for this type of thing is quite handy. A problem with dual diagnosis. So you have dual diagnosis, concurrent mental illness, mentally ill. The language is medically orientated and the duality is misleading. I think that's fairly explainable there itself. Confused, disorientated, bewildered. I know I've been doing this job for a long time and I'm still confused and bewildered at times with it all. The background. The issue of dual diagnosis has come to the fore over the last 20 years, so it's not something that's been around forever and ever. But in actual fact, it has. You know, even Freud used cocaine in his heyday. But the drugs have been there. And were people using them for treating different things? We don't know. But dual diagnosis has only kind of come over the last 20 years where people have realised there is an increase in people with mental health and substance abuse. The reason here is the increase in variety and availability of substances, an increase in polysubstance misuse, and deinstitutionalisation. And I suppose if people who have been in long-term institutions most of their lives go back out into the community, they're an easy target for people to kind of prey on, and then they get addicted to drugs. So there's a lot there. And the term dual diagnosis was used for the first time ever in this country in 2006 in the Vision for Change of Government Policy. So that shows you itself, like, you know, that's only 14 years ago, and it's not that long ago, because the Vision for Change is still the document that they're still using today. Okay, the prevalence of concurrent disorders is 46% of people with a mental health problem. They also have a lifetime substance use problem. According to the figures from the American Medical Association, 37% of people will abuse alcohol and 53% will abuse other drugs. Also will have at least one serious mental illness, and 29% of people diagnosed as mentally ill abuse either alcohol or drugs. And I think that's fairly, you can understand that. You're seeing it outside in your own practices. They run hand in hand and concurrently there together. Prevalence rates in the UK. And when it comes to prevalence rates, people aren't really worried about the numbers, and I say that in a very flippant way. It's only when it impacts financially onto services and onto the government. So you can talk about the percentage of people going up and up and up, but it's not until you have hospital admissions that they begin to sit up and take note, we need to do something. It's not until the addiction services are going out there saying we need more money, we need more help, we need more expertise, you know, that they begin to take note. So drug misuse related to hospital admissions in the UK between 2015 and 16, there were just over 8,500 hospital admissions with a primary diagnosis of drug-related mental health and behavioural disorders. And that was a 6% increase on the previous year, and 11% higher than 10 years before that. There were just over 15,000 hospital admissions with a primary diagnosis of poisoning by illicit drugs, and that was 6% higher than the year before and 51% higher than 10 years beforehand. So, and again, remember I said it's only in the last 20 years that dual diagnosis has actually been addressed. I mean, I started nursing many, many years ago, and I came across people who were coming in with depression who also had an alcohol problem, but the alcohol problem wasn't a problem, it was their depression. We never looked at alcohol, we never did anything about alcohol, except when you'd find alcohol in their beds and they would be discharged because they weren't compliant with the admission. But nobody addressed the alcohol back in those days. Again, deaths related to drug misuse in England. There were just over, almost 2,500 registered deaths related to drug misuse. This is an increase of 10% from 2014 and 48% higher than 10 years previously. And the deaths related to drug misuse are at their highest level since comparable records began in 1993. So you can see the figures have gone up. These are the UK figures, the Irish figures are much the same. Drug among adults, drug use among adults, again in 2015, again is much the same. The age range here is 16 to 59, equates to about 2.7 million people. This level of drug use is similar in 14 to 15, and this is interesting to say here that was significantly lower a decade ago. So you can see that the numbers have gone up, and that's just, we all know that. Drug use among children in the UK, 15% of pupils had ever taken drugs, 10% had taken drugs in the previous year, and 6% had taken drugs in the last month. And that's of young children in the UK. I went to a local school beside me here, a community school, to do work with their transition year students, and the teacher who was running the transition year programme, she was absolutely at her wit's end because she said they were coming in with cannabis, and she thought there were cigarettes initially, but she said it's just gone mental. And you can see here, 6% of 11-year-olds said that they had tried drugs at least once, compared to 24% of 15-year-olds. Somebody once told me that the youngest person that they had known in Ireland to use heroin was also 11. Ireland 2006 had 663 people were admitted to psychiatric hospitals with a drug disorder. O'Connor found that 43% of 137 patients admitted to a tertiary addiction centre in Dublin had a mental illness. O'Gara in 2010 examined cocaine use with mental health disorders using records from 465 alcohol-dependent patients. So they're alcohol-dependent patients who had used cocaine, found that 45.9% of the alcohol-dependent cocaine users, and that there was 37.2% of alcohol-dependent were non-cocaine users had a mental health disorder.